Hello dear friends, and this is a report from EASD 58th convention from Stockholm in Sweden. The weather is very pleasant over here, 10 degrees Celsius, and I am Dr. Jyotidev Keshavdev reporting from EASD, and I am from Kerala, India. So we have a huge audience here, huge audience. We are waiting for the last 2 years, and now post COVID there is a huge crowd and an exciting audience with lot of very enthusiastic topics. Let me start with tirzepatide. Tirzepatide is a dual incretin. As you know, GLP-1 has always been a very influential, exciting and successful molecule, and this tirzepatide is going to be a dual incretin which is an agonist for both GLP and GLP-1. So, what is new with tirzepatide? And this is a study presented at the 58th EASD convention by Mather and the group. Tirzepatide improved insulin sensitivity in this study. First and second phase insulin secretion has improved. It also enhances the beta cell glucose sensitivity, and this is a study comparing tirzepatide. Remember, this is a study comparing tirzepatide with semaglutide, 1 milligram of injectable semaglutide. The glucose lowering effect, the efficiency of tirzepatide in contrast to semaglutide. What are the results? It shows that the glucose lowering effect with tirzepatide is far superior, and there are improvements in multiple aspects of beta cell function, incorporating beta cell glucose sensitivity and insulin sensitivity ratio and insulin sensitivity, and there was a pronounced significant reduction with tirzepatide. There was a significant reduction in the fasting, the postprandial glucose levels when compared to semaglutide 1 milligram injectable. So, these findings from the study conducted by Mather aid to describe the higher enhancement in glucose control with the dual incretin tirzepatide compared to the comparators in the clinical trial. Hope this has been a very useful information for you in clinical practice. Which food is better? This is a debate. We have a lot of recommended diets. We have plenty of dietitians recommending all sorts of diets to our patients. In this study presented at the EASD by Chen and the group, ultra processed food consumption, they looked at the risk of development of type 2 diabetes, and these are the results from 3 prospective cohort studies conducted in the United States. So, let us now go into the depths of this study. A total of 17,432 type 2 diabetes cases were enlisted during 4784680 person years of follow-up. In multivariate adjusted analysis, higher ultra processed food consumption correlated with a higher risk of development of type 2 diabetes, and this association between the ultra processed food and the risk of developing type 2 diabetes remains significant even after further adjustment for overall diet quality. And the study concluded that ultra processed food consumption correlates with higher risk of type 2 diabetes independent of overall quality of the diet. Of course, these are facts which are already known to us, but this is a large study. This is a broad study, and the data is quite robust, and the results have yielded additional support to the already existing data for the suggestions of limiting. So, we as responsible physicians should be advising, counseling our patients and the population to limit the consumption of ultra processed food as part of a healthy diet recommendation, and this is now established to prevent the onset of type 2 diabetes in the population. What is the importance of diabetic foot ulcers? It is said that in every 30 seconds there are 2 amputations happening due to diabetes, and this has been a disaster, and this has been a challenge to every treating physician and surgeon. So, do we have anything new to offer to diabetic foot ulcer patients? Look at this study. This is from Rastogi and the group. A novel topical esmolol hydrochloride for treating diabetic foot ulcer, and this is a phase 3 randomized clinical trial. And this is again presented at the EASD 58th convention here at Sweden, in which there were a total of 251 participants. So, in this clinical trial there were a total of 251 participants and 176 were randomized to the group. So, esmolol was continued along with the standard of care treatment for diabetic foot ulcers, and esmolol along with standard of care resulted in substantial benefit, improvement in the ulcers, and these were those participants with a higher than normal BMI, overweight, with uncontrolled diabetes, with anemia, with various stages of chronic kidney disease, and those were the ulcers that did not achieve 50% area reduction despite treating for 4 weeks. So, in conclusion, esmolol along with standard of care resulted in 60.7% reduction in the ulcer area from end of treatment to the end of study. So, what is the conclusion? So, the concluding remark will be, this could be probably evolving as a new successful treatment for those unhealing ulcers. Topical esmolol is a novel treatment which can substantially enhance the chance of healing of diabetic foot ulcers than the standard of care, which is now followed in almost all the clinics. So, this is again an exciting news from EASD. Gliflozins are there for more than a decade now, but every week there is a new information, there is a new study exposing, revealing the unheard or incredible benefits of a gliflozin, and this is again back to dapagliflozin. Valency and the group presented a study at the 58th EASD convention. Patient with heart failure, we know that whatever be the stage of heart failure, dapagliflozin will be beneficial, and this is despite the fact whether the person has diabetes or not, and this is independent, it is regardless of the ejection fraction. So, what about initiating SGLT2 inhibitors if there is a clinical suspicion of heart failure and when the ejection fraction results are pending? Patients with heart failure with reduced ejection fraction, patients with heart failure with preserved ejection fraction, they are all likely to benefit from treatment with SGLT2 inhibitors, and that is independent of the fact whether they are diagnosed of diabetes or not. The benefit of SGLT2 inhibitors in diabetes prevention or diabetes progression also is now established. So, and that is especially in the scenario of pre-diabetes. The reduction in incident diabetes is expected in the reduction of microangiopathic complications as well. So, when you are treating heart failure patients with pre-diabetes with an SGLT inhibitor such as dapagliflozin, it is an attractive opportunity to prevent the progression to diabetes as well. So, when you are engaging, when you are executing your diabetes prescription, so when you are incorporating dapagliflozin even for the treatment of non-diabetic situations such as heart failure, you are in fact preventing the onset of diabetes or even preventing the progression of diabetes in those subjects with pre-diabetes. So, when dapagliflozin was launched 10 years ago, we never expected that this molecule will have such phenomenal benefits, which was never thought of at those times. Once a patient asked me, which is the most devastating complication of diabetes? I think the answer will be the same from any doctor. It is chronic kidney disease. Very disappointing, disgusting complication of diabetes. So, do we have really a drug to prevent CKD or to treat chronic kidney disease other than advising or recommending the patient to go for a dialysis or for a renal transplantation? Yes, now we do have a solution. We do have a solution, and that is finerenone. So, finerenone, this is a study presented by Schnell and the group, again at the EASD convention. So, in a patient population with CKD and type 2 diabetes, and these are in different stages of chronic kidney disease severity. But remember, these are subjects who are otherwise well controlled for both diabetes, for blood pressure, for cholesterol, optimized with RAS therapy. Add-on finerenone led to a very significant reduction in the risk of cardiovascular morbidity and mortality by 14%. So, 14% reduction in the CV, morbidity and mortality with the use of finerenone. Significant reduction in the risk of kidney composite outcomes by 23%, and significant reduction in heart failure hospitalizations by 22%, and dialysis again by 20%. So, this is somehow need to be regarded as a remarkable, miraculous drug, finerenone, and we are very glad that this is already available in our country in India, a drug at last for treating chronic kidney disease from progressing, and this is a blessing for those with chronic kidney disease and diabetes. And this is all from my modern medicine is so different. Modern medicine is so different from the conventional therapies, from the unproven therapies. We keep on improving, we keep on advancing, and whenever a new research is presented, we will, as responsible doctors, learn about it, study this in detail, and translate this into our prescriptions, and that is only for the betterment to improve the lives of those with diabetes and other illnesses. So, this is goodbye from me from Sweden. Until next time, bye bye.